So good morning, everybody. I'm Dr. Doble. I'm going to basically take about 10 minutes of your time and then segue into Dr. Feinberg's talk. So just quickly, mild TBI is the same as concussion. How many agree with that? Good. We're working on the education of not just the medical community, but the insurance community as well. And so the definition of mild TBI in the American Congress of Rehab Medicine statement is an alteration in brain function or other evidence of brain pathology caused by an external force. So the position paper goes on to say you don't have to have a loss of consciousness, you just have to have an altered sensorium. It doesn't have to happen immediately at the time of the accident. It can be something that progresses. And we all know the force can be shaking, rotation, direct blow, concussion like a blast injury, or the head hitting an object. So the shaking and the rotation is what we see most commonly in the mild TBIs with the cervical whiplash type injuries in a motor vehicle accident, or even the hits that we see in football games where the chest or the pelvis is hit, but the brain's snapping back and forth. So in the concussion clinic that we started at St. Joe's, we called it the Concussion Clinic because we figured nobody would sign up to come if we called it Brain Injury Clinic. and we see the patients. I started this in order to offload the patients that were treated and released from the emergency room because the ER doctors wanted to make sure that they were going to get follow-up, or from our trauma service who would admit and observe overnight, and if they were walking, talking, eating, drinking, and not a candidate for inpatient rehab, they'd go home. So they all come to the concussion clinic for follow-up care. So ideally, we would say most patients with a concussion or a mild TBI would get better over 2 to 3 weeks. And that would be fabulous if they all did, but we know that they all don't. So in our concussion clinic, 15 to 20% continue to have symptoms. And we call that post-concussion syndrome, which is the same as sequelae of mild TBI. So the mild traumatic brain injury person looks okay, but they feel like this. They don't feel well. And it may be just the tip of the iceberg that they say they don't feel well, and they can be having all of these symptoms. So in the post-concussion or TBI clinic, we spend a lot of time ferreting out what symptoms are really disabling for this patient and how to treat it. And this is a lot more time than a patient gets from their primary care physician in the follow-up from the ER visit. So we really try and identify those patients that need intensive recovery care in order to get back on track. So, this iceberg is really deep. And I think with global warming, it might be melting a little bit. But that's sort of synonymous with our understanding of post-concussion syndrome and mild TBI is really getting better with all the work that everybody at this conference is doing. I mean, it's pretty clear and obvious when a patient's in a coma that we recognize they have a brain injury. And it's pretty clear and obvious with the DBS trial guy who was impulsive and sexually disinhibited and kicked out of church that there's a real problem with this guy's frontal lobe. And you can probably see it on his MRI and his CT scans. But with mild TBI, you can't see the objective evidence on the picture, on the CT or the MRI, until we get much more mainstream functional MRI data. So we have to ferret this out very carefully. So what do? In the concussion clinic, we figure out who needs treatment and what kind of treatment. We try and get their pain under control, get them into therapies, get them into neuropsychology testing and counseling, because we want to, most of these patients, unlike my coma patients at Specialty, they're really in a hurry to get back to work, get back to school, get back into life. They're all anxious about wage loss and insurance benefits, and on top of that, they feel crappy. Sorry, on the videotape, but that's a true word. That's what patients tell me all the time. So the patient in the therapy program is making gains. We're in the outpatient TBI day treatment team meetings at St. Joe's, and speech tells me that they're getting better with attention and concentration, but they're still distracted by these headaches. And OT tells me they have visual problems, and they're not safe to drive yet, and they're not functioning at home with regards to bill paying and computer work because they say they can't see it or they can't attend their vision to it. So we get to the point of, in their recovery, and we're at, the 2 to 3 month part where they're getting better but not clearing, and we take a look at vision. So no pun intended, but we're going to look at vision. So what we found in this research that we've done is that binocular vision dysfunction is very often unrecognized. The optometrist at Sears or First Optometry tells the patient your vision's fine, and the patient is really not functioning visually very well. So binocular vision disorder can be caused by someone seeing double this way, someone seeing double this way, kind of on the oblique. And what causes that? Well, we know that a cranial nerve injury can do that, right? Remember the 12 cranial nerves, and 3, 4, and 6 are responsible for how the eyes work as a team. And if one side gets banged up, then that one eye isn't going to work as well as the other eye. They can have vestibular impairment, so that's a part of the picture here. And what we think is that there's a fusion center. How do the eyes fuse working together? Well, where is the fusion center? We don't know. It's like the Holy Grail. We're all looking for it, and if we can get into it with deep brain stimulation, we might be doing that in 20 years. But right now, we found another way to help the eyes work together. So this is a picture of a young man who's got what we call dysconjugate gaze. It's very obvious, right? So when we're looking at our patients, we're thinking, do we send them to neurooptometry or to neuroophthalmology first? Well, this guy needs a visit to the neuroophthalmologist, and that's the surgeon who looks inside the eyeball and looks at the optic nerve and looks at the trauma to the cranial nerve and looks at the way the ocular muscles are working and not working, as with this guy's left eye. And they say, okay, this is a problem, but we're not going to find something surgical to treat, and we're definitely going to watch this asymmetry over time because there's going to be some natural healing that takes place. And this is a guy that may need surgery or he may need a pair of glasses. We have to get his eyes aligned so he can function. This is an immediate post-trauma picture. This guy looks like he definitely needs an ophthalmologist. That eye looks painful. It's probably not. It's subconjunctival hemorrhage. All of the bruising tells us that he probably or might have orbital fractures, so that's definitely a visit to an ophthalmologist as well as maybe an oculoplastic surgeon. So these are the types of folks that I'm having the neuroophthalmologist take a look at pretty early and following over time. They may never need surgery, but we need to know from the beginning what the internal health of their eye and their eye structures are. So this is a picture of someone with vertical heterophoria, and it's meant to make you dizzy. And this is what a patient with binocular vision disorder, who looks pretty normal, if we could get that image to fuse, people would say there's nothing wrong with her eyes. But this is the way she's looking out at the world. And this is why she feels crappy. She's dizzy, she's nauseous, she can't pay attention to one image at a time. She can't keep the images in a sentence on the same line without using her finger. And is everybody dizzy yet? So I have personal experience with this. I had a cranial nerve weakness from birth, and it became progressive when I needed reading glasses. So I ended up eventually needing surgery, but before it became too bad, I had the prism to help my eyes work together. And it was an amazing personal experience that then enabled me to empathize with my patients and help identify them as candidates for sending to the neuro-optometrist, because the neuro-ophthalmologist had said nothing's wrong with them. So that's kind of the beginning of my journey of how I got involved in this. In my post-concussion / TBI clinic, about 30% of my patients that don't get better in that early 2-week to 3-month period of time actually have binocular visual problems. Some are getting worse because multiple other physicians in the medical community don't know what's wrong with them, and they're throwing medications at them. So they're over-sedated, their medications are contributing to their nausea, they're very fatigued, they're very anxious, and they're very depressed. So what do? They get more medications for depression and anxiety, which actually can have a chemical effect on the way the muscles of the eyes work. So if my patients aren't getting better in about 3 months with some of these symptoms, I'm thinking, let's look at vision. And I screen them with this questionnaire that Dr. Rosner will present.
On the back.
And I keep a copy in the office. And actually my practice has shifted over the years, so I actually have them fill it out on the first visit. So how many patients, they come into the office, there's so much paperwork to fill out on a new patient visit. Right on top, my MA has that yellow questionnaire, because the patient has given her enough information to know that I'm going to want that information. And I don't send them right to ophthalmology or neurooptometry after that first visit, but I have them repeat the questionnaire in a couple of months and see how they're scoring in combination with how they're functioning. So I talked about who I refer to neuroophthalmology, and I talk about who I refer to neurovisual optometry. And if they score more than 15 on that questionnaire, they're definitely a candidate for a neurooptometry eval. If they score 10 and they're very symptomatic, I'm going to send them anyway. And my patients don't just go to the clinic in West Bloomfield, Vision Specialists of Michigan. Some of them go to Ann Arbor Optometry, some go to Dr. Haba in Troy, but I want them evaluated by an optometrist that does this very thorough evaluation of how the eyes are working as a team. And what we've found in our mild TBI population is that the prism therapy glasses are a very efficient way to get them going again in rehab. Again, I mentioned these patients are overwhelmed with financial worries and work, do I have a job worries, how long can I stay off work, raising children at home, transportation issues, and they're all going to other therapies. And I find that putting them into the prism therapy glasses is more efficient than asking them to get into vision therapy right away, because they just don't have time for all of that. And once we get their eyes stabilized with prism glasses, then they can progress functionally through the basics of recovery and get back into their life, and then we reassess and reassess. It also allows me to get them off medications for their chronic pain, neck pain, eye pain, head pain, awful lot of medications for anxiety, and even my patients with post-traumatic migraine headaches get better. And I just have to mention that I don't just refer patients from trauma. I have lots of patients that come to me for headaches. The neurologists refer them because I'll do the Botox injections, and a lot of them have not been screened for a vision disorder. So they don't have to have trauma to have binocular vision disorder. It definitely enables the patients to function and participate more effectively in their cognitive rehab, their return to work, their return to driving, and their return to being able to work on computers, which is what most of us do in our work life. So this last picture is my puppy, because I'm not allowed to put a picture of my patient. So couldn't be HIPAA non-compliant here. So this is my puppy Sylvia. She's 6 months old. She's absolutely adorable. And I'll tell you the patient story in a minute, but I overheard my daughter saying at her graduation from high school party, the reason my mom needed a puppy was 1, because I'm going to college, 2, because our older Vishla is going to die, 3, because my younger brother is 12 and he won't let her baby him anymore, and 4, because Dad said no, and she doesn't like no for an answer. So one of the most recent patients that I referred to Vision Special of Michigan was a gentleman who had been for 4 years circulating through several different medical communities on multiple medications, had horrible headaches, dizziness, instability in walking, bumping into things, multiple fender benders because he didn't have the depth perception for driving. And he was very over-medicated. And so that's the kind of guy where every stone has been looked into. He's had multiple imaging studies. He's had neuro-ophthalmology evaluations. He's had neurology evaluations. He's been on multiple drug trials, and he's just miserable. That's a patient that I would refer on to Dr. Feinberg, head trauma or not, because this evaluation tells me, is it the eyes or not? And if it's the eyes, can we stabilize the eyes and get rid of all these other diagnoses and drugs? So that's a typical patient. I couldn't show his picture. In addition to the patient who's acutely injured and not getting better in the first 3 to 6 months. So with that, I will turn this over to Dr. Feinberg. You're next, right?
She's next.
And you've all heard her fabulous bio, so I don't have to say anything more.
Jennifer. Is it the right now?